All right, we get to nerd out a little bit over research, and I know I'm standing between you and lunch, so hopefully we can go through this. So I'm going to talk a little bit about our story, and my daughter's here in the back, I think sleeping. But how are we going to solve the mysteries of LGS? You had heard some great talks here, and now I want to kind of bring it home with research, and it's definitely the type of research that we're looking to fund at the LGS Foundation. So let me start with just our story. So this is me and my son and my daughter. My daughter was born typically and developed typically. She was very healthy until the age of 2. And when she was 2.5, she had her first seizure. At the time, this was in the 90s, the doctors didn't call them seizures. They called them spells and episodes because they didn't want to label her with something that would follow her for the rest of her life. Ultimately, we got a diagnosis of epilepsy at the age of 3 by reading it in her chart, because again, our introduction to the stigma of epilepsy was given to us by the doctors who were afraid to label a typically developing child with epilepsy, which I get it, but I also don't get it. Back in those days, we broke down epilepsy by symptomatic, cryptogenic, and idiopathic, which I still struggle with knowing. They basically mean structural would be the symptomatic, is the new name for it. Idiopathic, the new name is presumed genetic, and then cryptogenic. And she was diagnosed with idiopathic or cryptogenic LGS. They just didn't, or epilepsy, they didn't know. Initially, she only had 4 seizures. They were tonic-clonic. We didn't even know what they were initially when she started seizing. We thought she was choking. But by the time she was 3, she started having more than one seizure type. She quickly went to having hundreds of seizures a day, 6 different types of seizures. She had tonic-clonic, tonic, atonic, myoclonic, atypical absence, and she started going into status epilepticus. And again, back then we had this language, are they called grand mal seizures, are they called tonic-clonic seizures? So the new name for grand mal are tonic-clonics, and they do change the name from time to time. Petit mal, the new name for those, are absent seizures, or absent seizures, some people call them. But we were very, very confused in the beginning. And it wasn't until the age of 5 that she got the LGS diagnosis. She was sent to UCLA, we live in California, for a surgery workup to see if she was a candidate for brain surgery. And then we got the LGS diagnosis, and we thought to ourselves, oh, she's just been misdiagnosed this whole time. She's had LGS the whole time, but nobody knew it because we didn't do a long enough EEG. All of her EEGs were normal. All of her MRIs were normal. Her development was normal, but she's seizing hundreds of times a day. And back then, all we knew about LGS, it was very, very limited. We knew about this thing called the triad, which it's not really a triad anymore. We'll talk about that. In order to have LGS, you have more than one type of seizure. You have slow spike and wave on the EEG, and moderate to severe cognitive impairment. And we now know that that's not quite the story, which I'll talk about. We also knew that LGS was this umbrella definition, and you can have all these different causes, but this picture of this umbrella and this picture of this triad was really all we knew back then when she was diagnosed in 1998 with LGS. It was devastating. She was having hundreds of seizures a day, and over the next 16 years, she would have more than 40,000 seizures. And I counted them all because I am a nerd, and there was nothing else I could do. And I don't recommend that we count all the seizures for someone who did it for 16 years. I recommend to our families now to count the most problematic. But it was like seizures were normalized. They said, LGS patients just seize. And I'm not okay with that now that I know what I know about LGS. And hopefully when I get to the end of this, you guys will understand what I mean by that. Dr. Knupp showed the LGS treatment loop. We were in this, and Savannah, my daughter, tried and failed more than 26 different treatments. And that included medications, diets, devices, alternative therapies, thoughts and prayers, anointing, exorcisms, you name it. There was just all sorts of things that we went through, and still she continued to seize. And from the time the seizures kicked in at the age of 3 years old, she just stopped developing. She did lose some skills, but she just stopped developing. So by the time she was 18 years old, Savannah, like I said, had more than 40,000 seizures. She had tried and failed more than 26 meds. She was, on average, at the age of 18, having about 300 seizures every month, having them every day, and you never knew if you were going to get a 5-seizure day or a 50-seizure day. You just never knew. She was on 7 medications. She had a vagus nerve stimulator. She was on a special diet. She was getting rescue medications 2 to 4 times a week to stop seizures that wouldn't stop on their own. And we were losing her. She slept 18, 19 hours a day. She barely talked. She couldn't get her words out, and we were losing her. And across this time span, the definition of LGS changed 6 times. And this is going to become a little more important in our talk. But now you see, like back then when she was diagnosed, you needed to just have slow spike and wave on the EEG. But now you have slow spike and wave and GPFA on the EEG, right? And the criteria have changed. So LGS is somewhat of a moving target, but I think we've now landed on a definition. She was having all sorts of types of seizures still, and she still does. And it was a different story with every doctor that we saw. There's not just the diagnostic odyssey, but this whole treatment odyssey and the management odyssey. So we're going to talk a lot about that today. And we have a wonderful panel coming up later where the caregiver experts. We don't have very many people in our community or any that I know of with LGS that can come up and speak for themselves. So the caregivers come up and talk about what it's like for their diagnosis and treatment and management. So here's a snapshot of 16 years from the age of 3 to the age of 18 for Savannah. It took her 3 years to get the LGS diagnosis, and really I thought she had it the whole time, and we know better now. 7 doctors, 15 hospitalizations, 5 surgeries, monthly drug costs of about $1,600. Last hospital stay was $53,000. She's had 3 different skull fractures. I mean, it was just a hell that I don't have adequate words to describe. But here's what was really happening. Savannah was born and she had some cause of her LGS, and nobody ever explained this to me. But what her LGS is secondary to something. And I'll just tell you the punchline now. She has calcium channel mutations, which we didn't figure out till she was 18. But she had some unknown cause. And then at 2 years, she had her first seizure. And then she had 4 seizures total. And then she went 6 months with no seizures. And then the seizures came back at the age of 3. And now she has epilepsy. Epilepsy means you have 2 or more seizures in its simplest definition. Once she failed 2 medications, she now had treatment-resistant epilepsy. And we know that once you fail 2 anti-seizure medicines that were adequately tried, that your chances of responding to the next ones drops dramatically. But we didn't know that back then. Nobody told us, and maybe the science wasn't there. Then she'd begin to develop other seizure types, the developmental delay, and then at the age of 5, she developed brain damage, which is not a triad, it's a quadrad now, so it's seizures that start in childhood. That's the new addition. They always start in childhood. More than one type of seizure, developmental delay, which is actually not diagnostic criteria. Savannah was not delayed when she was diagnosed with LGS, but she was delayed very, very soon thereafter. And so many kids about 1 in 3 LGS kids are of normal cognition at the time of their diagnosis, but every kid with LGS has intellectual disability within 1 year of the diagnosis of LGS. So you have these EEG features. Thank you. Thank you. So this is going to become important in a minute for our journey with LGS, but a lot of our kids who are on anti-seizure meds go on calcium and vitamin D supplements, and this is because the anti-seizure medicines are very hard on their bones. And so in the beginning, for 10 years, nobody ever brought this up, and then all of a sudden they're like, oh my gosh, she has low bone density, and so they're like, she needs to go on calcium and vitamin D. So we put her on calcium, and every time we did this, she'd end up in convulsive status. And so after 3 tries with this, we're like, no, we're not putting her on calcium anymore. And it turns out you can actually just take vitamin D to help your bones. So she is on vitamin D and her bones are okay. And this journey that she went on is really what inspired me to go to college. I had not done well in high school. I had this kid that was seizing. I was a very young mom. And I was reading these scientific papers and I said, I need to go to school because I don't understand these papers. I clearly don't understand English. So I need to go take English classes. So I enrolled at the junior college where I had to remediate for quite some time because I hadn't done well in high school, and realized that none of these scientific papers are actually in English. They are in Spanish. No, I'm kidding. They are in medicine or they are in science. And the language of science is not the same as the language of medicine. So I spent 4 years at the junior college remediating, and then 3 years getting a bachelor's degree. And then I spent 4 years getting my Ph.D. in neuroscience, and then I did 3 years doing a neurogenetics postdoctoral fellowship, all at the University of San Diego. And I did this because there was nothing else I could do. My daughter was seizing every day, and we were losing her, but I could study. And so it just became, we all find whatever our lifeline is, and that was my lifeline to helping her. And I just wanted to be a part of the people who were helping, because what we heard from the doctors when she was first diagnosed with seizures, with epilepsy, was, thankfully we don't need to know what causes seizures in order to treat them. We have many, many medications. They would also say, seizures don't cause brain damage, which we know they do. They would also say, you can't die from epilepsy, which we know you can. And we're at home resuscitating our daughter, and they're telling us that. And these were the things that really drove me to want to come into the space and to try to help make a difference in the space. I just wanted to look for causes. What could cause a healthy 2-year-old to develop seizures? So Savannah's story has a somewhat happy ending, but before I tell you about that, I just want to say that LGS, what I know now about LGS, is that it is the sign of brain damage. When you develop slow spike and wave and GPFA on the EEG, something has gone horribly wrong in neurodevelopment. And we know that once you have those EEG patterns, those are the enemies in my mind in LGS. Once you have them, it becomes nearly impossible to learn and remember. And it becomes very, very, very difficult, very low odds of getting seizure control. And so LGS is a sign that something has gone wrong, that the brain has put itself together wrong. And I'll talk a little more about this. But it's not irreversible. It's not permanent. It's not forever static. It can be made better. We don't have any idea how to do that. But we know that it's possible. And I want to tell you a little bit more about that. So when Savannah was 18 years old, I was doing a postdoc in a neurogenetics lab. We sequenced her whole exome. This was my job in the lab. We found absolutely nothing, and for a year I did what I call crazy mother analysis on her genome, and ultimately found that she has calcium channel mutations, many of them, and she has a calcium channel overactivation disorder. And there was a clue to that in her getting those calcium supplements and having all of those horrible seizures. So there is a medicine out there used for the heart. It's used for high blood pressure and arrhythmia that stops the flow. So she has too much calcium going into her cells through calcium channels. And we want to slow that down. And there are actually medicines out there that do that. We put her on a medicine at 18 called verapamil. And within 2 weeks, she had a 95% reduction in her seizures. From 300 a month to, well, wait, before you clap, wait. Here's the kicker. Within 2 weeks, she went from years of going into non-convulsive status epilepticus 2 to 4 times a week to 0. And it was immediate. And now you can clap. Now you can clap. All right, there you go. No, it was, I feel like I met my daughter for the first time when she was 18 years old. And she went from, it took a while, but she went from 7 medicines and rescues and a device to 4 medicines, then to 3. She started talking again. She started sleeping less. She started walking and toileting. Not that she wants to, but she can. And I remember one time we were sitting there and I was going to go to some event and I had to get dressed up for it, and I sat on a bed and we were picking out a dress and jewelry and shoes together. And I started crying because that was a very typical mom thing that we did, and we just never had typical mom things. And so Savannah got me thinking, if you had told me medicine number 27 was going to be the medicine that helped her, I would have laughed in your face. And I have never been so happy to be wrong about something. You know, we thought the damage was done, and her EEG has gotten better during this time, and she's 29 years old now and continues to do very, very well. Now, we did have a little setback with COVID about 3 months ago, and she did need a rescue again and has needed some more, but we're hopeful we'll get that under control. But she's still doing great, and she's back here in the corner. She's running around with my crazy husband, and so you can look for them. But I hope you get a chance to meet her. But let's talk about how we're going to take this. This inspired me to think that LGS not only, you know, can be treated, and you can make a difference in an adult who has seized for 16 years and has had tens of thousands of seizures. But there's also evidence in the papers that it can be reversed. And there's also evidence that we strongly believe that it can be prevented, like Dr. Knupp and Dr. Porter were talking about. So let's talk about that. And here is the problem, and this is why we think this is the foundation's responsibility, is that even if you have the best doctors in the world and you get in there when your kid is brand new to LGS and you have all the money, there is no systematic way to stop, prevent, treat, reverse LGS. And we have to stop that, and we need to do it with research. And that's what we believe at the foundation. We've been treating LGS the same way for 30 years at least. We throw a medicine at it, we hope for the best, and we do not learn from every patient. And I believe that this community standing up, to the extent that you want to be a part of this and saying no more is what's going to make the difference, and pushing the research. And we've already made some efforts in that. So LGS, just to summarize, is you have your etiology and that whatever's causing your seizures. And then the seizures lead to abnormal brain waves, even before the slow spike in wave. And then you get LGS. Right? And then you now have these abnormal brain waves. And that, to me, what I believe it is, and we need to show this scientifically, is a brain wiring disorder. The brain is wired itself wrong. Because during the period of development, the brain wires itself when a child's brain is developing by electricity. And there's all this abnormal electricity, and we do need to show this. And once you have that slow spike in wave, once you have that GPFA, you get this slowing and you get this regression. So every one of us need to know the cause of our seizures that led to LGS. And if you look at the scientific papers, we can figure out the cause in about 90% of patients, according to scientists. If you asked our community, only about 30% of patients know the cause of their seizures that led to LGS. They could be injury, meningitis, infection, post-chemo seizures that then evolved into LGS, metabolic disorders, genetic disorders, malformations on the brain, disorders of glycosylation, autoimmune, there's all of these. About 50% of LGS cases are something genetic or genomic related, and the other 50% are something acquired, some sort of injury or insult to the brain in childhood. It's very important for you to find that. What science is telling us, though, is that we absolutely know almost nothing about what causes LGS. We know about the seizures, what causes seizures, but what causes the seizures in some patients to evolve to LGS? So it's something like about 30% of Down syndrome kids develop seizures. And I might be a little off on these numbers, but about Down syndrome kids develop seizures. In addition to all, they have trisomy 21, they develop seizures. And a small percentage of those kids evolve into LGS. Not all of them, but a small percentage. Why is that? We have no idea. But science is starting to unlock this. And the LGS Foundation has funded some of this research, and I'm so excited. And what it is the LGS network, no matter what your etiology, there's 1,000 causes. Your etiology just means cause. There's 1,000 causes, whether you're genetic or acquired. All converge, no matter your age, no matter your cause, onto the exact same epileptic network in the brain. Epileptic network is different brain regions that are wired together talking to each other. And they're supposed to be talking to each other in a very typical way. That's abnormal in our kids. It starts in the cortex, it runs down into the brainstem, it comes up to the thalamus, and it is the same network. And that's what we're finding in all of the kids. And this is the LGS network that underlies GPFA and slow spike in wave. And we know that when you have this abnormal network, that it disrupts two systems, the executive control network and the dorsal resting network. Let me just tell you what those are in English. The executive control network, if you're paying attention to me right now, that is on in you, right? If you're paying attention to anything, actively thinking, that's the executive network. The resting network is if you're daydreaming. So if you're not listening to me, if you're sleeping, not sleeping, but if you're not paying attention, you're daydreaming, that's the dorsal resting network. There's evidence that these are both on at the same time in LGS kids. And we have a lot of science and work to do to understand this, but maybe that is why they can't learn. So there's research to look at this network. And this network is important because if you have the cortex, which is a brain region, talking to the brainstem, which is a brain region, talking to the thalamus, which is a brain region, what is under all of those are neurons and cells, and that's made up of proteins and signaling pathways. And we can start to look at the genes that underlie, and we can start to think how we might target that. And the LGS Foundation just funded one of the first LGS mouse models that has slow spike in waves, so we could start to dissect this and understand, is there a way to modulate this network? So once you have it, it's leading to not only the cognitive impairment, the regression, the increase in seizure susceptibility, the behavior dysfunction, but it's also, and I'm so sorry to tell you all this, but over time, that network is developing atrophy. And what that means is that the cells are dying. It is neurodegenerative, it is slow. Over time, the atrophy develops, and a lot of us with older kids will go to the hospital and say, oh, you have generalized atrophy, or you have atrophy here. We're seeing atrophy in this network, which means the cells are starting to die, which is a neurodegenerative process, and we have a lot of work to study that. So how are we going to advance research? The first thing we need to know is what matters most to patients and families. And so I'm going to present to you some work that we've talked about that we've done since 2018 with our community here. We have a community of more than 8,000 members. We had 413 families respond to the survey, actually 416. And we tried to get at the idea of what is the hierarchy of needs in LGS? What matters most to patients? And most of you guys might remember Maslow's hierarchy of needs from psych class. At the bottom there, like if your physiological needs aren't met, you're never gonna have a great life, right? Lower quality of life, like if you're not getting food, if you don't have clothing, if you don't have shelter, you don't have safety, your quality of life is poor. And then up at the top, if you have all those things at the bottom of the pyramid, then you can live a better life. So what is that for LGS? So the first thing we asked you is the current number of seizure types your kids are having. So again, 416 caregivers responded here across the survey. Some answered and some didn't. So some were having 0. 2.8% of our respondents had 0. A couple of patients said they were having 10 different kinds of seizures, and it ranged. Most were having between 3 and 6 different kinds of seizures. We also asked what were the most problematic seizures that the loved one was having. And we hear doctors, I go to scientific meetings all the time, and they're like, we're really good at controlling generalized tonic-clonic seizures. You guys said that we're not. Generalized tonic-clonic was the most problematic. Tonic seizures were next, drop, and then atonic after that. But our kids have every type of seizure. We have focal seizures, we have myoclonic, we have atonic, and it's different for you, but this is what the majority of patients said. We asked how many treatments you guys were on, and most people were on between 2 and 5 treatments currently. And in a way, that's an experiment. We don't have a lot of data about how all these medicines are working together in conjunction with each other on the background of our children. And so I'm going to be telling you guys that we really need to be learning from every patient. And then what did we ask? Oh, and then we asked about how frequent the seizures were. So these were the different kinds of seizures, and basically 60% of the people responded that they were having weekly tonic seizures. 37 reported weekly drop seizures. 59 reported weekly atypical absence. So people were having many, many seizures, mostly on a weekly basis. And here's a nice summary of the data. This was actually a second survey that was done by the Rare Epilepsy Network. The most with LGS had poor seizure control. When they looked at behavior, 14% had never sat up without help, 24% had never walked, 43% had never spoken a 2-word sentence. Seizures across the last 6 months were between 1,000 and 5,000. Our kids are having tons of seizures. And they looked at the same numbers in other rare epilepsies like Dravet syndrome and tuberous sclerosis, and they were between 500 and 1,000. We are having so many more seizures. We don't win any prize for that. They all suck. They're all horrible. But lots of seizures. And then lots of comorbid conditions with autistic features, ADD, behavior. And then we said, okay, you're having all these problems. 97% of you are still having seizures, 87% sleep disturbances, 81% head and face injuries, 80% severe developmental delay, not mild, not moderate. 76% behavioral issues, 73% use a wheelchair at least 75% of the time. 72% can't read or write, 69% can't write, 72% can't read. 60% were nonverbal, 50% were hospitalized in the last year, and 30% were tube fed. So we asked you to prioritize these things, and this is what we heard from the community. The first thing was seizures and safety. We need help from the foundation and from research on seizures and safety. We are not doing a job. Developmental delay was next, especially communication. How do we know what our kids are communicating? How do we know if they're in pain? How do we know if they're hungry? How do they know? How do we understand them? Next was behavior, especially aggression. Then mobility and physical issues, sleep, costs and access to care, and social isolation. So we have 99,000 problems. We have 99 problems, And this was the priority that you guys put them in for us, and that was very important. You also told us, and we wrote this paper with Dr. Ann Berg from Lurie Children's, that epilepsy and seizure burden are more than just the seizure. And you can see that the seizure is represented by the red spike here, but all of these other issues, the anxiety that comes, the prep that we have to do for the next seizure, and then there's the aftermath of the seizure, cleaning up the pee, cleaning up the poop. Am I going to make it to work? Are they okay? Did they aspirate? Are they going to get pneumonia now, right? And on and on. So seizure burden is so much more. And it's not just the unpredictability of seizures or the frequency or the severity of seizures, which are the things that we'll often count when we do studies, but it's this whole long-term implications. We can't make plans. There's an impact on our siblings. There's all the medicines and the sleeping behaviors, the fear of SUDEP, chronic sleep deprivation. In addition to that, we're overloaded, we're anxious as caregivers, we have trouble with our marriages and our families, we're not thriving, and it culminates into a chronic traumatic stress disorder. There's no post. And so this is something else that we need to work on with all of you. And so we have our work cut out for us. So what is the hierarchy of needs in LGS? It's right here. We spend most of our time in survival mode down in the red, in crisis. Seizures, status epilepticus, injury, infection, respiratory distress, in the hospital, giving rescue meds, aspiration pneumonia, which is the #1 thing that kills our children when they swallow saliva during a seizure, they get pneumonia. That's the leading cause of death in LGS. We spend most of our time there. So of course our quality of life sucks, right? We spend a fair amount of time in safety mode, trying to avoid crisis. Are our kids breathing, eating, sleeping, drinking, pooping, peeing, taking their medicines, and safe? Like, we're not even talking about, like, they come and they're like, let's talk about a seizure-safe school. I'm like, I don't even have a seizure-safe home. What are you talking about, right? And then we spend a fair amount of time in coping mode, which is avoiding crisis. Do they eat, sleep, drink, poop, pee, and do they do any of it independently? And the answer for almost all of us is no. And so our quality of life is in the red and the orange and the yellow, and it never gets up. You know, our kids are of course, they are loved and they're belonged, but we're constantly in crisis. And so our job is to get you guys out of crisis, so you're not in the hospital all the time, and we're not using rescues, and how do we move the needle on that? So just a few more slides here in my last couple minutes. To advance the research, we need to understand this evolution of LGS. Here's some data. The first seizure usually comes first, then the spike and wave comes, then the tonic seizures come, and then status starts. This was a small study. We need to fund research on this. No one else is going to fund it if we don't. And we need to understand this so we can prevent the evolution. We need to understand that each of these arrows on this graph represents an intervention point to prevent the evolution to LGS. Also, when you already have LGS, to prevent the evolution to further neurodegeneration. We need to be studying this network and breaking it down and trying to reverse and prevent the EEG abnormalities. We need to talk about, I'm just going to fast forward to this. We need to talk about learning from every patient. It makes me crazy that we don't have a natural history database. I don't know where Jackie went. But this is a graph of 22 people who had LGS. And if you look at the very top line, they had a few seizures in the beginning of the first year. They were followed for 9 years. They had a moderate number of seizures in the dark blue. And then they were seizure-free from year 5 to 9. Who are these people? Where are these people, and what can we learn from them? Look at this. Cognitive outcomes in LGS. Here was a study, again, of 24 patients with LGS. 3 out of 24 of them were seizure-free and off medicines and had typical cognition. Where are these people? Why aren't we learning from them? This is a great case here. Here's a patient who got, this was actually 3 patients, but this is just one of them, got referred very late in life in their teens because they missed their brain surgery window. Brain surgery still remains the highest percentage odds, the highest, you have the best chance to get seizure control. Had a frontal lobectomy or a regionectomy where they removed the region of the brain. If you look, had slow spike and wave, preoperative. Had generalized fast GPFA, is just PFA there. Look at day 30, normal EEG, seizure-free. Who is this person, and why aren't we learning from this person? And then finally, to advance research, we need patients and families as partners and co-designers in the future of treatment. And I'm showing you this DC subway map because I'm a scientist, and I work with a lot of conditions, and we certainly are, and you're in here, and we love you. We're never going to get there without you, but the amount of time we spend with doctors and in research is like 4 stops on that red line compared to this entire map. And the entire map is LGS, and our LGS journey roadmap looks something like this. We've got our research line, and yes, it's a few stops, and it's very important. But we're at home with our seizure and safety line. We've got our diagnosis and treatment line, our LGS-associated disorders, our school and community. We're out in all of these lines, and we're going on our red line stops, to the doctor, but they're not coming out to the ghetto over here with the how are we managing life, in the community. And so we want to work with them. We want to help them, and I think we can do that. My time is up. I just want to say we want to keep continuing the conversation. We have a lot of research programs here at the LGS Foundation. We fund research grants. We are moving the needle on it. We have research roundtables and meeting of the minds, and we'd love for you guys to get involved in that if you're interested. But mostly, what we want you to know is there's hope. For those of you that are in here, I have a 29-year-old, and you're thinking about the future, and maybe you're seeing some of these kids, and you're terrified, and you're overwhelmed. We are fighting for a better future for you. All of these people here that are older and mentors, we're fighting for a better future, and we would love for you to join that. If you don't like the word fight, to join that effort. We'd love for you to have it.